Good evening, everyone. It's a privilege to welcome you all to the Young Family Physicians Forum organized by the Sri Lanka College of Specialist Family Physicians. I would like to welcome you all, especially our madam, Dr. Lalata Senaratne. Amidst her busy schedule as a clinician, she never misses a chance to teach us. So she's also here today, and she has been continuously doing this for years now. So let me introduce our speaker today. He's Dr. Chaminda Senaratne, a third-year registrar in family medicine, currently working in University Unit, Ragama. And he's going to tell us about the invisible illness. So it seems it's invisible for now, but I hope at the end of this presentation, he will make it visible. Over to you, Dr. Chaminda.
Thank you, Dr. Supun, for your kind words of introduction. Actually, I welcome you all for the presentation, especially Madam and all my dear colleagues. Uh, can you hear me well?
Yes, we
Yes.
can hear you.
Yes. Today I am going to discuss actually the condition you may see. This is invisible illness. Actually, today my target is to make you visible. I mean to at the end of my presentation, if you can visualize this illness, I have done my job well. So let's see what is this condition. Uh, First, I will start with the uh, I will start with the history. Uh, this is this is regarding a 42-year-old patient. Is a female diagnosed patient with bronchial asthma and dyslipidemia. This patient presented to me uh, with shortness of breath. Basically, 42-year-old asthmatic patient presented with shortness of breath for 3 months duration and with history of chest pain. She had on and off chest pain also. But this chest pain does not uh, relate to shortness of breath. Uh, and uh, Further history, shortness of breath was on start 3 months back. It was with shortness of breath with mild exertion, and it was progressively increased over the last 3 months. And recently, that was very severe chest pain, severe shortness of breath. Even talking, given the history, also make her dizzy. However, she managed to do her normal day-to-day activities with this shortness of breath. Uh, this did not associate with cough or wheezing. And also, she complained about a chest pain, but this not uh, associate with shortness of breath. Uh, Actually, before 1 week to the presentation, she had a severe chest pain during night at about 3 a.m. That was a sleepless night. Yeah. And at 3 a.m., she had a central constrictive type chest pain, which was severe, very severe. Pain score was 8 out of 10. And that pain has radiated to neck, but no autonomic features. So in this presentation up to now, basically 42-year-old patient with shortness of breath and chest pain. What are the differentials you may think uh, you may think in this level before going to the further details? Can anyone think few differentials? Uh,
Angina?
yes, Supun, and that also a possibility. Yes, that also should be in the list. Angina or ischemic type chest pain or heart failure. Yes. Any other differentials? He is asthma patient and shortness of breath, chest pain.
Respiratory tract infection.
Yes, that also a possibility. And as even asthma exacerbation also a possibility. Respiratory cause also there. Yes, fine. Any other thing?
Pulmonary embolism.
Yes, that also we have to consider, but it is 3 month history of shortness of breath. But even we should consider pulmonary embolism, as Taranga said. Yes. Uh,
Pneumothorax.
yes, that also possible. Anything for shortness of breath possible in this scenario. So keeping those things, and these are the my differentials. Actually, I thought of cardiovascular causes like ischemic heart disease, heart failure, and respiratory causes like uncontrolled asthma, COPD, any malignant conditions, lung carcinoma, pulmonary embolism, pulmonary effusion, fibrosis, interstitial lung disease, even chronic infection like chronic atypical pneumonia, TB. The those are the respiratory causes, and also hematological conditions like anemia, as is female anemia also a possibility. Even psychological conditions, functional hyperventilation, depression, and also anxiety. It may be generalized anxiety disorder or panic attacks. And also this patient was bit obese. So that I thought of obesity, hyperventilation syndrome, and also thyroid diseases, and even fibromyalgia also a possibility. Keeping these differentials in the mind, I went further details. Uh, uh, in the detailed history, he had poor sleep, lack of energy, and lack of interest, and also fatigability was there. Had body pains mainly involving shoulders, back, and legs. Uh, and there was no features suggestive of hypothyroidism. And also there was no features of heart failure even. And there was no clinical evidence of bleeding. And she didn't have fever or headache. And also she didn't have any fractures, or she was not being bedbound following surgery, or no history of bedbound. Uh, and she had 30 days cycles of menstruation, but these uh, had a heavy menstrual bleeding. Even it was 3 days, he has fast clots with in menstrual flow. And she is a diagnosed asthma patient on Beckley metered dose inhalers, and the compliance was good. The condition has been well controlled. And also asthma patient, she was on Atorvastatin also, and she didn't have hypertension, ischemic heart disease, congestive heart disease, and he had no COVID infection, and also had no past history of joint diseases also. There was no significant family history of allergic history, uh, and she was a housewife, mother of 2 children, and husband was a businessman, and he was very supportive. Mm. When the patients, when I asked about his eyes, actually she think this shortness of breath may be due to dyslipidemia, I mean with the high cholesterol. And she is concerned that because of this lipid levels, he may get heart attacks, and she is worrying about her children. And he he expect from me to relieve those from these symptoms, and also he want to get done CT pulmonary angiogram as suggested when she was in the hospital. She want to does that test very early. I mean, the date has given, it was bit late. Uh, Now, after the history, this is the summary. Actually, this is 42-year-old housewife presented with shortness of breath, on and off chest pain, breath and on and off chest pain more than 3 months, with the recent history of admission to hospital with atypical chest pain. Uh, she had features of depression, but there was no features of heart failure, no features of hypothyroidism, or no evidence of blood loss. And her asthma and the dyslipidemia was well controlled, and she was worrying about the chest pain and shortness of breath, uh, which might which might be due to high cholesterol. She thinks that due to high cholesterol, and she wants to relieve with these symptoms. So with this summary, I went to the my examination part. During examination, in general examination, her BMI was 29. That of that is she is bit obese. You can consider as stage 1 obesity. And there was mild pallor also. There was no icteric, and patient was dyspneic but not cyanose. In cardiovascular examination, pulse rate was 100 beats per minute with regular beats and good volume. Blood pressure was normal, and the respiratory rate was also high. It was 22, but lungs was clear. No additional breath sounds. Abdomen was normal, not distended. Central nerve system was normal. Her wide disparate pain score was 7, symptom severity score was 5. Actually, I will explain what is this pain index and the symptom severity score in my later slides. And PHQ-9 was 9 out of 27 marks, and the Minicock was 5 out of 5. Basically, she didn't have any cognitive impairment, and PHQ-9 was 9, so there was mild depression. This is the symptom severity score and pain score which I calculated. In this patient, wide disparate pain score was 8 by the calculating painful areas. Uh, I will explain it in later. And also symptom severity score. It was 1, 2, 6. It was 6 for this patient. The total was 14. Fibromyalgia score was 14. This is the PHQ-9 9 score. This gave 9 out of 27. So these are the investigation which has done while the patient was in the hospital. There are the full blood count says the hemoglobin level is 10.2, and blood picture says iron deficiency anemia. The indices are low, and also serum ferritin was low. So she is having iron deficiency anemia. Other than this abnormality, other investigations was all normal. Trop-5 was normal, D-dimer was normal, and lipid also fairly normal. Uh, Thyroid function normal, echo was normal, creatine was normal. But she couldn't complete exercise tolerance test because of shortness of breath. At stage 1, she had to stop because of shortness of breath. So now after the history examination and investigation, let's see the summary. Right? Then this is the summary. Basically, she is a 42-year-old housewife presented with shortness of breath, on and off chest pain more than 3 months. Recently, she developed atypical chest pain and was admitted to the hospital. Her troponin I, ECG, and 2D echo was negative. Uh, then BMI was 29, then the mild pale and dyspneic. PHQ-9 was 9 and Minicock was 5. According to the ACR 2016 criteria of fibromyalgia, fibromyalgia score was 14. This is the summary. Then actually at that point we can have some problems. We can diagnose some conditions and some problems. The problem list which I identified: mild anemia, iron deficiency anemia, overweight, and she was highly concerned about chest pain and consequences. And also she has features of depression and also features of fibromyalgia. So I started the management. This is how we manage this patient. We explain the condition to the patient. As pharmacological management for the iron deficiency part, we started Animidoc as he was afforded. He told that he can afford for Animidoc. We started Animidoc 1 capsule nocte. And also there was for the depression part and the poor sleep, we started Sertraline 50 milligram and Alpha-Salam 0.5 nocte. And non-pharmacological management, lifestyle modification, diet and exercises we advise, because this patient had complained low abdominal pain. So we want to, I wanted to review the patient with the UFR, and also because of the heavy menstruation, so I thought of doing the ultrasound scan abdomen also, and plan was to review in 1 to 2 weeks. Opportunistic health promotion was also prescribed. So that is the management of this patient. With all the problems, because I was bit much interested about fibromyalgia, so I thought of discuss about this condition and how to diagnose this condition with you. My plan was to discuss this fibromyalgia with you. So this fibromyalgia, it considers as a somatic symptom disorder. Let's see what is this somatic symptom disorder. Actually, somatic symptom disorder it is diagnosed when a patient significantly focuses on physical symptoms. Focus on physical symptoms such as pain, weakness, or shortness of breath to a level that result in major distress or problem for functioning. So there are I thought of discuss few important conditions under this: fibromyalgia, chronic and chronic fatigue syndrome, tired all the time syndrome, and myofascial syndrome. Let's see one by one how to diagnose and how the patient present like in each condition. First, let's see fibromyalgia. This considered as a syndrome characterized by multiple somatic symptoms and tender points. This patient has somatic symptoms with tender points. Currently, there is no diagnostic test for diagnosis of fibromyalgia. However, the diagnosis of fibromyalgia is bit challenging. Diagnosis, we should diagnose correctly, and the management should be patient-centered. And explaining about the fibromyalgia to the patient also a bit skillful task. It is also difficult. When we consider in the epidemiology, it is a global problem. Primary care prevalence is 3 to 4%, and it is mainly female predominant, 1 to 7, and it is unrelated to ethnicity, culture, industrialization, or wealth. Long-term problem. This is a long-term condition, but remission is there. 25% people can go into remission. Occur in patient with coexisting conditions. Actually, patient with arthritis, osteoarthritis, and chronic disease, this can be coexist, and also may be associated with chronic fatigue syndrome. When we consider the pathophysiology, actually the pathophysiology has not clearly understood. But there are some theories. It can occur due to central nerve system that alter the processing of apparent sensory input. Here in this condition, non-painful stimuli being amplified as and non-painful stimuli experienced as painful stimuli. And also they have sleep disturbances, unable to have good sleep. And there is altered level of substance P, serotonin, growth hormone, and also serum cortisol, and also cortisol response is to the cortical response is blunt. And if when we done MRI scan, there are some changes in amygdala, thalamus, and insula. This is the pathophysiology. Then let's see how fibromyalgia is diagnosed. Actually, this is the important side in this presentation. I think according to the 2016 ACR diagnostic criteria, there should be widespread pain index greater than or equal to 7, and symptom severity score should be greater than or equal to 5, or widespread pain index should be 4 to 6, and symptom severity score should be greater than or equal to 9. This should be there to diagnose fibromyalgia. I will explain how to calculate and how to examine the patient to calculate this number. And these symptoms, these painful, and these symptoms should be there at least 3 months to diagnose this condition. Symptoms can be coexisting with other conditions also, and fibromyalgia is valid irrespective of other diagnoses. So let's see how this pain areas is calculated. Our body can be divided into 19 parts from front and backs. These are the 19 parts. So there are 19 parts. I think you can see. Then we have to calculate. When we examine the patient, we have to see what are the areas patient complain of a pain. So we have to calculate the painful area. Out of 19 areas, how many are painful? Painful. Let's see the painful area. Number of painful area is 8. Then the widespread pain score is 8. That the 8 comes like that. That is for pain index. Then we have to calculate how is the symptom severity score. So in this chart, symptoms in last week, I think you can see the arrow, isn't it? The fatigue. There are some features: fatigue, weak, awakening, unrefreshed, and cognitive symptoms. So those 3 symptoms we consider mild, moderate, and severe, and we give 1, 2, or 3 marks. If the patient is fatigued, if it is mild fatigue 1, moderate fatigue 2, or severe fatigue 3. Like that, we give marks. And also for other symptoms, there are 3 other symptoms. One is headache, one is abdominal pain, other one is depression. For each condition, we give 1 mark each. So that total mark here may be 12. Out of 12, how many marks the patient is uh, getting? So in previous our patient, the patient had fatigue. We gave 2 marks, and awakening unrefreshed. For that we gave 2 marks, and there was no cognitive impairment in with our patient, and she had abdominal pain and she had depression. So our symptom severity score was 6 for our patient. Likewise, we have to calculate symptom severity score. So when we have calculated wide disparate pain score and symptom severity score, we have to add two to together. Then fibromyalgia score comes. So the fibromyalgia score should be more than 12. I mean, with the wide disparate pain score equal or more than 7, plus symptom severity score more than or equal to 5, altogether 12. Or wide disparate pain score should be 3 or more, plus symptom severity score should be or more than 9. That is how we calculate. If this is more than the fibromyalgia score more than 12, we can diagnose fibromyalgia. That is how we diagnose fibromyalgia according to the 2016 ACR guideline. So let's see. Yes, that is how we diagnose. So these are some differentials we have to think when the patient we when the patient when we think about fibromyalgia. These are the differentials. Uh, those are hypermobility syndrome, polymyalgia rheumatica, and also poliomyelitis, some malignancy, vasculitis, even hypothyroidism, multiple sclerosis, neuropathies, uh, and chronic fatigue syndrome, and also patient taking statins as a side effect, Lyme disease. All these conditions we have to think of. These are the conditions associated with fibromyalgia. Actually, depression, our patient had depression. Likewise, dizziness, irritable bowel syndrome, fatigue, and sleep disturbances, headache, chest pain, all these conditions can associate with this fibromyalgia. And let's see when is fibromyalgia is easily missed. Actually, most of the time we miss this diagnosis. Uh, we are tend to miss the diagnosis because this is coexisting with a lot of conditions. Usually, it coexisting with arthritis and also endocrine disorders, depression, and with sleep apnea. And also, fibromyalgia also report with patient with SLE and also patient with osteoarthritis and also with diabetic patient and also some patient with hyperthyroidism also. Uh, let's see the management of fibromyalgia. Actually, this is team management, medical management, allied health team, and also alternative medical practitioners. All we have to involve in the management. But the family physician has the greater responsibility. He is the coordinator, and the main role we have to play the main role, but we have to involve other team members as well. In the management, we have to educate the patient regarding the clinical features and the pathological mechanisms. And also we have to we have to offer some psychological intervention. Also, we have to address depression management, and also cognitive behavioral therapy, and also mindfulness also important in this management. And
In
exercise.
progress.
Hello. And exercise also we have to offer, and some physical therapies like yoga, tai chi, and those I mean rhythmic dancing exercises also very important. In medical management, uh, actually, especially there is no special drug available. According the ULA recommendation, simple analgesics we can recommend like paracetamol. Actually, NSAID has no much research evidence. Antidepressant has a role. Usually, the usual antidepressant is, I mean, tricyclic antidepressant, but SNRI, SSRI we can offer other than tricyclic antidepressant. When we give amitriptyline, that is the usual drug. We give low dose of amitriptyline. Other than amitriptyline, we can offer duloxetine or also fluoxetine, and also membrane stabilizers like pregabalin, gabapentin also we can prescribe. Uh, when we consider the key points in fibromyalgia, in fibromyalgia, physical examination is required, but tender point examination is not required to confirm the diagnosis. Actually, in the previous guideline, we were used to calculate number of tender points, but this guideline tender point calculation is not there. Only the tender areas we have to calculate, and limited investigation is considered. Management should be multimodal and rehabilitative, and it is teamwork, and it should be patient centered. Non-drug approach is there. Patient and care education should be there. Patients who advise on exercise, and cognitive behavioral therapy also play a major role. Let's see what are the referral criteria for this condition. When the diagnosis is uncertain, or if we are not sure about the diagnosis, we can refer to a rheumatologist. And if the patient is not physical, like I mean, with the treatment, if the patient is not improving, we can refer the patient to a psychiatrist. Patient not responding to initial therapy, and also there is a place to refer. And also prominent mood symptoms. Patient with prominent mood symptoms, we have to refer to a mental health professional. And also, if the patient is having sleep problem, we have to refer to a sleep specialist. Actually, there are no sleep specialists in our country, as I think, as I know. So let's see another condition that this other than this fibromyalgia, this condition also very I mean this also a common presentation, but we tend to easily miss these conditions also. This is chronic fatigue syndrome or myalgic encephalomyelitis. Here the main symptoms are fatigue, post exertional malaise, unrefreshing sleep, cognitive impairment, and orthostatic related symptoms. These symptoms, in this condition, these symptoms should last more than 6 months in mild, moderate, or severe intensity. Let's see what are the criteria to diagnose chronic fatigue syndrome. In later slide, let's see the epidemiology. It's 2.5 million people in USA. Young people, young to middle-aged people also in all this condition. This also more in females, few from lower economic groups, but that means more from higher economic groups, few from lower economic groups. They are this in this condition also etiology is not clear. There are several etiological mechanisms they suggest. Infection has a role, immunodysfunction, endocrine metabolic dysfunction, depression. These are the suggestive etiologies. So let's see the diagnosis criteria. In chronic fatigue syndrome, this is the diagnosis. For the diagnosis, fatigue should be there, post-exertional malaise should be there, unrefreshing sleep. Those three conditions should be there, and about three symptoms for more than 6 months. These three symptoms should more than 6 months, together with one of below. I mean, or cognitive impairment or orthostatic intolerance. These three symptoms and below one, at least one symptom should be there for last 6 months. And also mild to moderate in intensity, severity should be mild, moderate, severe, and at least 50% of the time of the day. Those are the criteria to diagnose this condition. So we have to do some investigation just to exclude other conditions, not to confirm the disease, but to exclude few other conditions. In the management most of the time supportive and focus on symptom relief. Actually, for the symptom, we can give painkillers and we can give antidepressants. And cognitive behavioral therapy also has a major role. And gradual exercise therapy and diet also, we have to prescribe a balanced diet and good sleep, rest and relaxation. Those are the management, and that is for the chronic fatigue syndrome. Let's see another condition, that is tired all the time syndrome. TAT, tired all the time syndrome. Actually, this condition also extremely common presentation in general practice. Should focus on physical, psychological, and social issues. Let's see the epidemiology. In epidemiology, occur in all age groups. 50% of the people in chronic disease report feeling and tired. Actually, people with chronic disease, 50% of people have this condition, but we never diagnose or we never think this condition. That means it is very common. Annual incidence is 1.5%. So these are the differential diagnosis for the condition: depression, obesity, or obstructive sleep apnea, poor sleep pattern, hard work, and also treatment with sedatives, caffeine, and also chronic fatigue syndrome, also a differential. Yes. So in this condition, actually there are no criteria to diagnose in tired all the time syndrome. So we have to go through the history for the diagnosis of the condition. In the history, we have to ask, see what is they mean by tired, or fatigue, and duration of tired. Ask about the previous uh, level of energy, and also any other problems, any other changes. Reason starting any medications, and recent weight loss or weight gain, any changes in appetite. Likewise, we have to go in a detailed history, and also polyuria, nocturia, bowel habit, menstruation. We have to ask about the sleep, alcohol, and also drug history, occupation. Like we have to diagnose from the history and examination. In the examination, uh, by the we have to see the general appearance and the BMI and the pulse. Like uh, those are the examination points, and these are the investigation we can perform to exclude other possible conditions. Possible conditions. Yeah. And when we consider in the management, there is no special drug. The physical management, there we can consider physical management, psychological management, and also lifestyle management. In considering physical management, appropriate management of physical problem, uh, is important. If the patient is having iron deficiency, we have to treat for that condition. Sometimes a patient with respiratory failure can present with fatigue and somnolence, and patient with OSA can present with lethargy, somnolence, and poor concentration. So to avoid this tired all the time syndrome, we have to address almost all problem which comes with each condition. E- uh, each conditions. Yeah. And physical activity and psychological interventions we have to done in patient like in rheumatoid arthritis. Some in cancer patient we have to offer aerobic exercises. We have to offer gradual physical activity and exercises. As psychological management, psychological distress is common with lethargy and fatigue. So that we have to assess psychological conditions and psychological support we have to offer. Mm. And for the lifestyle management, we have to identify the social and life issues that are responsible. The patient may be in position to address them, but even if they are unavoidable, someone has discussed them, and even those problems are unavoidable, even even though when discussing with the patient, that itself gives a resolve to the patient. And also we have to address drug and alcohol misuse. Therapeutic trial of antidepressant we can give as a part of the drug management, pharmacological management. Uh, so let's see another condition which comes as somatic symptom disorder, which is myofascial pain syndrome. This is much similar to fibromyalgia. Let's see how this condition is. A chronic condition that causes pain in the musculoskeletal system. Pain is confined to a particular area, uh, associated with trigger points in the muscle. In these conditions, there are trigger points. Trigger points radiate pain to the affected area. When we compress the trigger point, the pain radiates to the painful area. That is in myofascial pain syndrome. Uh, Here the primary symptoms are localized muscle pain and trigger points that activate the pain. When we compress the trigger point, pain is activated. There are some other problems, other symptoms also. Those are muscle stiffness, fatigue, poor sleep, headaches, and also postural abnormalities. For the diagnosis of myofascial pain syndrome, we can do some imaging actually to exclude other condition comes as imaging for exclusion for fractures or any other painful conditions of the muscles. Imaging and diagnostic test to rule out conditions that cause pain. And we can apply gentle pressure to feel for tight muscle bands and trigger pain. We can palpate tight muscle bands. And we have to, for the diagnosis, we have to look for postural abnormalities. Uh, and we have to think how often experience the pain. And this whether we have to find are there things that make it better or worse. Likewise, we have to come to a diagnosis of myofascial pain syndrome. Actually, here I have make comparison between the myofascial pain syndrome and fibromyalgia. Actually, most of the symptoms is there in myofascial pain syndrome also, but fibromyalgia it is in more condition. I mean, if the fibromyalgia is elder brother, myofascial syndrome like younger brother. The symptoms are less compared to the fibromyalgia. Let's see the management of myofascial pain syndrome. We can give cold laser, also known as low-level light therapy. We can offer cold laser and dry needling. We can insert a small tiny needle to that painful areas, I mean pain points, and that itself reduce the pain. And also we can offer wet needling also. By wet needling, we can give some injection. Electrical stimulation also we can do. And also massaging, stretching in uh, stretching exercise and we can do. Stretching exercise also we can offer, and also transcutaneous electrical nerve stimulation TENS also has a role, and also ultrasound wave therapy also a part of the management. And also dietary management also there are some diet diet cause inflammation. We have to reduce those diets with inflammatory features. I mean, tomatoes, fruits, nuts, olive oil, leafy greens, and fatty fish. Those reduce inflammation. And also we have to avoid ingredients that trigger pain. There are some foods that trigger pain. We have to avoid those things. And also heat therapy, behavioral modification, and also physical therapy also, physiotherapy also have in a part for that management. And also we can offer acupuncture, also NSAID for the pain, lignocaine patch, muscle relaxant, steroid, duloxetine, which is SNRI, and also anticonvulsant, antidepressant, and also Botox type A also has a place in the management. So these are the actually four conditions which I want to discuss with you. At the end, this is I have put some question. I mean two questions. Can you give the answer for this question. Which of the following condition is characterized by physical symptoms that suggest a medical disorder, but there is no underlying medical diagnosis or separate medical disorder? What is the answer? Can someone answer, or can you put in the chat box? Which of the following condition is characterized by physical symptoms that suggest a medical disorder, but there is no underlying medical diagnosis or separate mental disorder? A. Illness anxiety disorder. B. Functional neurological disorder. Somatic symptom disorder. Munchausen by proxy.
B.
Yes. B or C?
B. Functional neurology.
Yeah. Actually, yes. I have got three answers. One is B, one is B.
Somatic symptoms disorder also can
Yeah.
symptoms but no diagnosis.
Yeah.
Multiple symptoms.
Yeah. Because of the multiple symptoms, the answer they have given is C, somatic symptom.
Somatic, yeah, that is the answer.
Yeah, that is the answer. Somatic symptom disorder. Uh, the question says characterized by physical symptoms. Physical symptoms that suggests a medical disorder. Seems like a medical disorder. There are some lot of physical symptoms, but there is no underlying medical diagnosis. So it is somatic symptom disorder. Let's
In
see.
functional neurological disorder, there won't be any uh, physical symptoms, right?
Yeah,
Yeah. Okay.
yeah. Uh, yes. Let's see the another simple question. So this also, let's see. Uh, you can see the
Yes.
uh, about the epidemiology of the somatic symptom disorder. Occur in adults. Up to 17% of patients in primary care clinics, patients are most likely to be male. The disorder does not occur in patients with recognized medical conditions. What is the answer?
Sit A.
Occur in adults. No, it can occur in even young person,
Children, young children
young
also.
young children also. And
D.
patients are most likely to be male. That's also wrong. Female,
Females. Females.
all the conditions we discussed was more prominent in females. The disorder does not occur in patients with recognized medical conditions. Most of the time, this associate with other medical conditions. So that's also wrong. Actually, the answer is
B.
B. The somatic symptom disorders are up to 17% of patients in primary care. See that it is very common. I mean, 17% of patients with this condition. I mean, somatic, there are 17% of patients in primary care. But these are in USA studies. There are no studies, I think, in our country. There may be more than that in ours. Actually, these are my reference. Uh, this is the end of the presentation. Is there any things you want to clarify or any problems or anything you want to highlight, or I would like to answer any questions. Did you?
Dr. Chaminda, can you please tell me how did you interpreted the cognitive impairment of this patient?
Actually, Tarindra, there was no cognitive impairment of this patient. The minicog was done. Minicog was 5 out of 5. That is you are asking.
Yes, I'm asking about that. How did you get the symptom severity score? What were there any somatic symptoms and about the cognitive impairment?
Tarinda, when we get the symptom severity score, the in our patient, she has fatigue. In the symptom severity score, components are fatigue. One is fatigue, other one is awakening unrefreshed. Other one is cognitive symptoms, and other one is other symptoms. Other symptoms Under other symptoms, there is headache, abdominal pain, and depression. For the fatigue, they they are given 3 marks. One for mild, two for moderate, three for severe. In our patient, she was bit fatigued, so I gave 2 marks for the fatigue. Awakening unrefreshness component also I gave 2 marks. And cognitive symptoms, for the cognitive symptoms, I assess cognitive symptoms by uh, mini-cog test, by clock drawing and the remembering three things and the clock drawing. She got 5 out of 5. That means there was no cognitive impairment for that patient. So the she got 4 marks for the fatigue and awakening and refreshness part for another two, and also in other symptoms, she didn't have headache, but she had abdominal pain and she had depression. For that, she got 2 marks. So total was 6 marks.
So, cognitive impairment is not an essential criteria to diagnose fibromyalgia, is it?
Yeah, the symptom severity score should be, I mean, the total fibromyalgia score should be more than 12. In that, sometimes some patient cognitive impairment should be there, or no. Without cognitive impairment, we can have that desired, I mean, symptom severity score. We can have 9. I mean, the fatigue we can give 3. Weak awakening and refreshness we can give 3, or even other condition we can give 3. Without cognitive symptoms, patient can have fibromyalgia. Yes, according this, I mean this criteria. If the patient is
And
fulfilling the criteria, we can uh, diagnose as fibromyalgia.
okay, and the other one is you mentioned about the BMI being 29.
Yeah.
And have you like ruled out any primary sleep disorders? Did you check stop bang or Epworth, and you are sure that she doesn't have any OSA as well?
Yeah, actually, I didn't do all the stop brand criteria. I just asked about snoring and things, but those was not there. But the patient was obese. I mean, the BMI was 29. Uh, Actually, yes, I didn't do all that criteria to diagnose OSA. Just asked about the snoring and things, but it was not there. I didn't give marks and uh, other. The proper assessment was not done actually.
And my last question is there a particular reason that you didn't start on a SNRI, duloxetine, at the first place? Because there are certain studies done that duloxetine plus pregabalin has more efficacy.
Okay.
And the other thing is, you said that we don't have any sleep specialists, but we do have in here. And recently, by the respiratory specialists, they did a workshop as well on sleep hygiene, and especially in MRI they have a sleep clinic with
Where
the
is the system?
respiratory physician
Where is the
and MRI.
MRI?
Yes, and when we usually refer patients to the respiratory physician or the neurologist or the ENT surgeon. All three levels, they conduct sleep studies.
Mhm.
Uh, the anything that you have to say about duloxetine and pregabalin, because I think now the first line they are using is duloxetine. That's all. Thank you.
Actually, Tarindra, this when I present this to my trainer, actually trainer was wanted to start these two drugs for the depression. He was bit interested in about thirdly, and because of the sleep problem, we added alprazolam and bit for anxiety also. Uh, that's how sertraline comes to the picture. Uh, Otherwise, I thought of adding amitriptyline because it caused pain reduction and it's a bit sleep. I mean, the having the side effect of sleep also. But antidepressant dose may be higher. I mean, the low dose of amitriptyline does not. Uh, uh, it is not the depressive dose. I think that may be the reason to not to start amitriptyline by my trainer. Actually, I didn't know why he didn't go for duloxetine without. I mean, for sertraline without giving duloxetine. Probably maybe the cost. Or actually, I didn't ask about that. Thank you for your information. Uh, any other?
Dr. Chaminda, one more question. Is it all right?
Yeah.
Yeah, this is regarding just too interesting. Have you followed up this patient with the ultrasound scan?
Yeah, actually, I ordered only the ultrasound scan. Patient did not. I couldn't review with the report actually.
Because why I'm asking is the
Mm.
primary diagnosis could be fibromyalgia,
Yes.
but there are few red flags seems to be,
Yeah.
because the SOB were there, the NYHA classification seems to be 4, and
Yeah.
according to the history, also there is a tenderness were there in the LIF region.
Yeah.
You have mentioned in the abdominal examination.
Yeah.
Also having some kind of heavy menstrual bleeding.
Yeah.
I'm just thinking about like knee symptoms. Some problems with the abdomen, chest, and maybe menstruations. Knee
Yeah.
symptoms could be. So on top of we would may miss something. That's why
Yeah.
I'm asking.
Yeah. That's true. That's why we ordered ultrasound scan also. I think there may one of my colleague or any other doctor may have seen the patient. Actually, I couldn't see the patient with the ultrasound scan report. The reason why we ordered this is because of that heavy menstrual bleeding. We want to see whether the fibroid or any other uterine pathology is there, or any abdominal pathology was there. That's why we did uh, this scan. Actually, we couldn't see. Uh, yes. Think, but abdominal. Yes, left iliac fossa tendon was there. Yes, that's where I mean the patient did not have any fever, but we want to do a UFR and ultrasound scan because to exclude these things. Uh, yes, you are correct, but I couldn't follow the patient.
Thank you very much.
Yeah.
Chaminda,
Yes, Sahanga.
I have one question. You might have told this during your lecture. I missed it. Should we have tender points to diagnose fibromyalgia? Without tender point, can we diagnose fibromyalgia?
The tender point calculation was in the previous guideline. Now the guideline
Yes.
has been updated. Now the
Yes.
updated one is 2016 ACR guideline.
Okay.
In the previous guideline, we should have tender points. We should
Yes.
calculate how many tender points in the patient as we tender points. But in this line, they say tender areas, not the tender points.
Yes.
So out of the body has divided into 19 areas.
Yes.
Out of that 19 areas, how many painful areas in the body? I mean,
Right.
yeah, if there is 7, they consider as wide disparate pain index as 7. There is
Right.
1 out of 19. That that, that is how the new guideline has changed.
Okay. Can we go for diagnostic score without a single tender point?
No, we can't.
Tender area. We can't. We should have.
Yeah, I will go that side. Yeah, wait a minute. I think this is the very important side in this presentation. This is the, you can see, no?
Yes. Yes.
Here the wide disparate pain index greater greater or equal to 7. That this 7 is that 10 areas. And symptom severity score greater than or equal to 5. So we should have at least 7 tender points here.
Yes.
Or
To
to diagnose. And there is another one, pain index, widespread pain index of 4 to 6. That means at
Yeah.
least four tender points should be there. Here,
Okay.
we should
Yes.
have 4 to 6 tender points, 10 areas, and symptom severity score should be more than.
Chaminda,
Madam,
hello. Chaminda, now just the matter of just change the words. They use the area instead of points. There's
yes,
actually no change. That's WPI, of course. It was there for years and years. Like this one, of course, the widespread pain index, WP index is they use instead of the word the tender points. So we have a higher chance of diagnosing patients because of this WPI. It's not just a point because it's areas. So sometimes when you press, if this is not tender, then we say it's negative. But because of this area, there are higher chance of not missing this that fibromyalgia diagnosis, right? So that is the reason. That's why I put this is very important slide. You have to highlight that. That I heard the way you are discussing is good, very enthusiastic. It's good, but like this person, the way he patient presented with SOP, right? That is short of breath. Maybe the person is having cough and underlying bronchial asthma. It could be that. Or else this, tell me, what is the singular word for SOB?
Hatigatiya, madam.
Hati, Mahansi.
Yes,
even the tiredness.
yeah.
Is there any difference in singular words? Tiredness.
Tired.
So if they say tired, like
means
Mahansi.
Mahansi.
Yeah, Mahansi is Mahansi. So when they say Mahansi, we have in English tiredness as well as SOB. So that is the misleading sort of the term you use most of the time. That's what when a patient comes with some sort of a difficulty of we'll say Mahansi, don't interpret as SOB. That is the problem. When the person says Mahansi, it could be SOB, it could be tiredness. Are there any singular, any other different word? No. That is the interpretation is a problem.
Yeah.
So you have to be very careful. This tiredness, right? They say Mahansi for everything. SOB is tiredness. Tiredness is against Mahansi is again tiredness, or else just even sometimes some difficulty like breathing, mean in the sense like some test tightness, even they use the word Mahansi.
Yes.
That is the thing that I'm always telling the train is to interpret what the presenting complaint. That is the thing. So we cannot say anything about this because the patient is having underlying maybe the respiratory symptom. It could be aggravated. I mean, we do not know that at the beginning. But as a clinician, if the patient say Mahansi, what do you mean by this Mahansi? Is it tiredness? And it's just tightness? What is it? Because when you translate it Mahansi to the SOB, then you're in trouble. So that's the main issue.
Madam,
As yes. Tehettu is again, sometimes they say Tehettu. Tehettu is where, I mean, like even tiredness. So they don't say the words. They Mahansi, they say Mahansi. For each and every, even for sometimes, when they have some sort of a, maybe they don't have energy to work, the lack of energy, even the word used is Mahansi. Right? That is a problem. If they don't have energy to work, lack of energy, even that, they say Mahansi. You have to be very careful when you interpret to English term as SOB. If you are going in a separately wrong way, wrong direction, right? So that's you are like going here and there, this is SOB. Yeah, but this is very straightforward patient with, the fibromyalgia. The words you use is a problem. But I kept it like that to give you some sort of insight. So the hereafter, you'll be very careful when you interpret the presenting complaint, because don't translate what the patient is saying. In the same way, not only SOB, even for the vertigo, they use several words for this. Karakavili. It could be just vertigo. It could just imbalance. For something they use the word. Even faintness, praising copy, for everything they said Karakavilla. It's a disequilibrium, they use Karakavilla. So don't use the word vertigo for that. So it will be very careful when you use words. Right? That is the first mistake. It's mistake in the sense for everybody they use. But anyway, what I'm trying to say is your presentation, as I mentioned earlier also, it's very comprehensive. So people who know the subject, you have done the good job. How do you use all the symptoms, and then you get the correct diagnosis. You have to use this WPI and the SSS. It's very important. That is how we do the diagnosis. And only thing, as one person highlighted, you cannot use whatever according to your wish, the management, right? So the other mistake is this depressive part, or else some sort of a low mood or whatever. It's a part of this disease. You cannot just take it separately at depression. It's a part of this. Don't treat separately the depression. No, it's a part of the disease. Right? So totally wrong, the use of sertraline in this patient, I must say, right? But I kept it just to give that message to you all, right? Because it's a part of the depressive is, don't say the patient is having this. And because, you know, in SSS, it's there, all the symptoms are there. The symptoms could be like some symptoms related to depression as well. But it is this particular illness per se has all these things. If if the person doesn't have this, all the SSS, you cannot diagnose even fibromyalgia, right? So as somebody mentioned, I think the Chaminda, actually we have to go for either there are like a lot of medication. Even TCS, okay, even 25 would do. Other than that, you can go for the other rest of the thing. Duloxetine, fluoxetine. Duloxetine is the best. But anyway, if you think the cost, I think most of the hospitals they have, it's not difference, right? But anyway, the fluoxetine also is not a problem. Okay, you can go for that, right? And even amitriptyline. But there is no place of NSAID, but you can go for gabapentin, yes. But most importantly, make the patient give them understanding what it is. It is not arising from your just a joint disease. The problem is somewhere else. That is how you feel it. It's a normal perception actually. You have to say, or you perceive it. It's not the normal because you have other issues, ongoing things in your your life. Because of these things, you feel it, but it's not like you have to go for some painkillers or some sort of maybe if they, according to their words, you have to use the words, the painkillers of some sort of anti-inflammatories, don't go for those things. That is how you perceive it. So by giving this kind of understanding and giving the flow, either some sort of fluoxetine or duloxetine, even after 1 month, they show the huge difference. I think there were few patients. There's one of you in the audience, they can remember how the people they responded very quickly. So it's a matter of just explaining and giving the correct medication. Don't take joint pains, depression or whatever the things separately. It's a whole thing in one box, right? And anyway, what I like is you nicely, because there are people still are sort of very poor in diagnosing this disease because they don't know what is WPI, what is SSS. Now you correctly mentioned everything. It's very nice. Other thing is, though the patient comes with some tiredness or whatever, if you don't ask the rest of the thing, because of the first 2 slides, you gave the main complaints. Like SOB, you mentioned the word SOB. And you nicely, because it may be related to respiratory, it could be related to cardiac, you gave all the symptoms. And from the 4th slide onwards, you nicely mentioned, you showed your capability, how you go in, the depth, the further information, how to take the further information. Because most of the time, that is the art of family medicine. If you take only the first few symptoms, the differential diagnosis, because with the first 2 slides, though you mentioned fibromyalgia, you cannot put fibromyalgia in that. But from the 4th slide onwards only, you can put it. But that is the reason I kept it. Okay, fine, let's keep it like that. So this is out of, yeah, it's I'm telling, though it's under the rheumatological disease, but the rheumatologist, see, I think I'm 100% guarantee you as specialists or like family medicine, people who are practicing, you can have 100 times chances of diagnosis because you do a nice comprehensive assessment of the patient, right? So I think you have a higher chance of getting the diagnosis because you do a good comprehensive assessment of patients. So these are the things in particularly things, yeah, with the, that low abdominal pain and the patient has mild anemia as well as, this bleeding problem. Okay, it's additive. Yes, you have to because it's opportunistic, okay? Or else you want to get the understanding of the ongoing illnesses. Yes, you have to do, but this is a pure case of fibromyalgia. It's very, very clear cut. Those things, how can we say a human being only have this particular yeah, they have this particular, the main diagnosis this, but anyway, there may be underlying ongoing illnesses as well. You have to do, it's your duty. You cannot say I'm not a person who practice gynops because of that I do not know. We as the physicians who can give all the like sort of support for the patient, it's your duty to do those things. Either it could be UTI or it could be something else, or maybe adenomyosis. We don't know, I cannot remember the age. Could be whatever, right? So it's your duty to do that job. Anyway, it's very good. It's a good eye-opening for the, that's why I told you, very comprehensive. It's very good. Those are the things, because if I correct you at the beginning, you also not learn, because that's why I kept for the others to learn that part. I think it's good for everybody. It's good that you ask questions. That is what actually only listening will not help. You have to, asking questions means you actively participate. That is or else the brainstorming, or like you share your knowledge with the others. That should be the way. These are the main objectives of this particular presentation. That's why I give you all the guidance, but I keep it as young physicians forum. It is not though I help, it's not my forum. It is yours. I'm there to give the guidance to y'all to become one day a good, comprehensive, like maybe very skillful consultant. Okay, any more thing you want to add? I just keep, okay, anything you can add. Anyway, thank you very much.
Thank you very much for the explanation, madam, and the support given by you during my presentation. I mean the preparation of the presentation also. Thank you again, madam, and also thank you my all other colleagues also who gave me the support during the asking questions and giving support for the preparing the presentation also. Thank you very much.
Thank you.